fundamental mission for the Department of Medicine is education, and we now understand that the best way to educate our students, our residents, our fellows, and even ourselves is through direct observation. On the spot, getting feedback from a master clinician and educator on how we're relating to patients. This makes us better doctors.
Our team's goals for this session is to enhance all of our skills in direct observation and feedback. We believe that well-planned direct observation with actionable feedback is one of the most important education methods we have to advance the skills of medical students, residents, and fellows.
So the opportunity for direct observation is different than evaluation that happens at the end of the rotation. It's a chance to teach. So I do make time for it, but I fit it in where it can. Any opportunity that I have to go into a room, even if it's for 3 minutes, to watch a fellow talk to a patient, we find the chance to set that up and debrief it afterwards. And that's how I fit it in.
If you try and do direct observation by not planning, it won't work. You need to really plan in advance how you're going to observe someone and get the resident to buy into that patient being directly observed.
The essence of direct observation is really how you learn and grow as a physician in training.
It's the basic core of feedback, that if I can see something that a student or resident is doing, and I can suggest a different way to do this, this might help a student or a resident to get better and make some changes, and it doesn't take much time.
You would not expect a football coach to run a team without watching his players practice. So it doesn't make a whole lot of sense to be training our residents without watching them interact with patients.
When I'm doing direct observation and I see a resident or a fellow make a mistake, I think one of the important things is to realize that that's a learning opportunity and not make it something that needs to be highlighted in any negative way.
And knowing that you could be the factor of harm in the care of a patient is, I think, the humble realization we all have to get to, which makes us aware of our limitations, and that we should take our time during the learning process, not to do everything at once. Well, feedback can and should be given after each and every clinical encounter, be it a brief visit to the patient in the setting of the clinic, or it could also be after a long procedure.
So when it comes to giving tough feedback, I don't really want to do it. I stop, though, and think, if I was in the position of that learner, would I want someone to tell me so that I could become the best physician I could be? Since that's what I would want for me, I push myself to do that for my learner.
Giving feedback is one of the hardest things we have to do with our trainees, is they take it very personally when you do that. Nevertheless, there's no other way to help them understand where they are and how to get where they need to be.
So as a program director, the direct observation tool provides me highly granular information for each fellow that is vital in being able to assess the fellow and their competency in their role as a pulmonary and critical care physician.
I think it really rings hollow when at the end of a week or a month you say, you did a great job. And the learner walks away with, well, what did that mean? Whereas when you did this, it worked. That allows for really internalizing that concrete message and taking that to the next patient.